Thank you for inviting me this morning to share with you some of the things that as an occupational therapist will do for the client with MND. So this is the outline for today's presentations. Okay. Some of the objective I hope that everyone can meet after this session will be having a better understanding of the overall OT when handling a patient with MMD, and also be able to actually help to actually verbalize some of the simple intervention that we can actually help to improve the quality of life of the patient as well. Okay. So some of the function in terms of MMD, I think is something that we are all very familiar with. MMD is actually a chronic neurodegenerative disorder of the motor system. It actually reduce the muscle strength and wasting without any sensory disturbance. And we all know that every patient with MND present very differently, and their rate of progression is also can be very different. Okay, so some of the some of the symptoms of MMD can be presented in some of the isolated or affected function as shown. It can be a limb features whereby they tend to fall and trip very easily, a loss of dexterity, and they have muscle wastage. Some of the patient has bulbar features whereby they have some difficulty in swallowing, weak cough, and excessive saliva, which I believe later Melinda will be sharing more about her role in this. And also respiratory features being SOB quite easily, having morning headaches. And some of the patients with MMD do have some cognitive features whereby they tend to have some behavior changes, emotionally more labile, and it was actually known that a small percentage of MMD patient does present with some features of frontal temporal dementia. Okay, so by knowing all those things that is actually what our patient will be facing, right? I think for the OT, we actually look at different stages of their disease and actually help to implement different intervention along the way. So this is just a summary of what we will do at different stage of their disease progression. So moving on, if you guys are not very familiar with my occupation, so basically occupational therapy, we are actually a type of healthcare that helps to look at solving problems for patients, especially this problem is interfering their ability to do things that are very important to them. These things can be as small as their day-to-day living, which is things like self-care, being able to dress, eat, and moving around the house and being productive as going back to school, work, and also moving around in the community and participating in all their leisure activities. But as the OT, we actually offer a fairly set person-centered assessment and intervention with the mind of aiming to maximize the functions ability of a person, to help to ease the care and also reduce the caregiver burden and maintain quality of life. And we also explore different type of intervention, equipment to strategy or adapting how people do things to address the different problems of the person to actually enhance their participation in everyday life. And the most importantly next is actually empower the family, the caregiver, and also patient with resources as well. So some of the thought process that is always go through our mind as an OT, we're actually looking in terms of the three aspects. We look at a person as an individual, how this person interact with their environment, and also their occupation, being a student, a mother, a father, or as a patient of or their work as well. Okay, so we'll look at a person's values, their skills, and also their sensory motor function. We also look at their social environment, social support environments, physical environment as well, and also their roles and activities. Okay, so with all this information, we see how we can actually integrate, capitalize their ability, minimize their strength, minimize the weaknesses to maximize the fit of this three interaction to help them to be more enabled. Okay, so this is just a summary of what we do and what services we provide. We look at early education, adaptation of ADLs, caregiver training, prescription of equipments. It can be wheelchair switches, orthosis for the upper limb. We also look into a cognition and also look in terms of different cognitive strategy to help to maximize a person's ability to do things. We also look at activity modification to help with the fatigue management and energy conservation. We do home visit and look at environment. Okay, and some of our OTs actually are trained in driving, so we do driving assessment if the patient is medically fit for driving. We also have another group of us actually looking in terms of workplace modification to liaise with employer to look at how we can accommodate a person in their current duties and job scope. If we want to further streamline to be more lean about what a role of OT, MMD, basically we are a group of people that have helped to support person with MMD and their family to express their choice, have the control and develop goals together. And we all know that MMD is not a very it is actually a very dynamic and very complex medical condition. So it is our duty to actually liaison with different professionals to actually have a more coordinated collaboration to help to meet the goals of the patient. So sometimes we do work with the physio and we do work with the speech therapist to actually achieve certain goals for our patients. And it's actually very important for us to have an ongoing assessment and reassessment for patients to address the ongoing functional changes of the person as the disease progresses. So for a quality of life, what exactly is in the eyes of everybody and also patient with MMD? Basically, quality of life is actually defined by WHO that it was a perception of their position in life in context of the culture and value system which they live in, and in relation to their goals, expectation, standards, and concern. And some of the indicators of the quality of life are as follow. It can be a wealth, employment, environment, of physical, mental health, social belongings, recreation, religious beliefs, safety. But in the eye of a person with MND, these few might be the main indicators of their quality of life. But of course, as I said, it's actually varies from person to person. So this is just a rough possible indicator. Okay, and knowing all those things and knowing the role of OTs, right? How can we help to improve the quality of life of a person? Okay, and we all know that the whole disease actually it tends to limit their activities and participation level. So as an OT, we can actually look in terms of activity modifications, okay, and also environment modification through home modification and also caregiver training, and also looking at terms of the wheelchair fitting to actually maximize their mobility and comfort as well. Now I'm going to bring you through the intervention of a OT in this various aspects. So the first thing first, we are looking at activities of daily living adaptation. Okay, so one of the things that we always look at and we normally label this group is actually called self-care training. So through self-care training, we actually look at adaptation of tasks, looking in terms of use of equipment to help to maximize the independency of a person with MMD. And the equipment that we suggested can be as big as a mobile commode, wheelchairs, it can be as small as just a feeding spoon that we use it day to day. Okay, so what we'll do for a feeding task, right? First thing first, we'll look at the we'll do assessment of the upper limb, and also looking at the position of the person for when they are doing eating, see whether how we can maximize the function, and the measurement can be like looking in terms of their positioning and sitting for the feeding activities, looking into their actual sitting system, see whether there's a need to have a better head or back support, and also their arm support, and also seeing whether the height of the feeding table is it appropriate or not, whether do they need a lower one or a higher one. And we also look in terms of equivalent prescription to help with the reduced grip and control. And the following are some of the feeding equipment that we are looking at for patient. Adapted utensils like a enlarged handle for the spoon, angled spoon, okay. And we are also looking at whether is there a need for a suction bowl, or just a normal non-slip mat with a bowl to prevent any movement of the plates and bowls. And looking in terms of like having a plate guards to actually help them with the scooping of the food, and also some of the things like a bilateral cup holder to allowing them to use their wet space to hold on to the cup instead of using the grip instead. Okay. Next thing is we are look for dressing and grooming. Okay. We all know that with the progression of the deterioration of the muscle strength and dexterity, some of the equipment that we might suggest to actually help them to maintain their independency. It can be a long-handled brush, especially if they have difficulty with their gross motor movement. Okay, a button hook or zip puller, a long-handled reacher, or even like shoe horn, shoe aids, socks aids. And we might actually suggest to family members to remodify the clothing of the person, by having, instead of using button, we use Velcro. Instead of having pants with zip, we are looking at rubberized pants. And also to actually, some of them we might actually suggest them to change the zip by having a additional loop with using things like more sturdy strings, or even using those paper holder, the ring holder, and also changing the button to those as magnetic. Yeah, so it actually helps to solve the problem of having a poor dexterity. For shower and toileting, um, for us, we actually look at how we can optimize the task and also modify it. And some of the equipment we might recommend will be the shower commode for patients. And this shower commode, we have to decide whether is it with some of the tilt function or recline function. Later, I'll be showing the picture in the following slides. Or say some of the things like a grab bar, is it necessary to use a grab bar? If the patient is a little bit more bed bound, should we actually look at in terms of having inflated shampoo basin or bathtub for them so that they can have a clean self as well, good personal hygiene. Okay, so these are the grab bars that we are looking at. Okay, we can also suggest for some raised toilet seats with armrests, especially for patients that have difficulty in doing sit to stand as the disease progresses. Okay, a bedpan for them to pass urine in the bed, or urinal. And so this is what I mean by the shower commode. So basically, shower commode, we look in terms of whether they are stationary, mobile, whether can it be a normal commode like what is shown here, and also whether can it be a tilt in space commode. Okay, but again, when we are looking at all these equipments, we will be looking in terms of their space, and whether it's to understand whether there's a possible space constraint that we are facing. Okay, and also a shower chair for a more stable person at their early stage, a long-handled um, bath sponge if they have difficulty reaching their back, and also this is the inflatable shampoo basin that I'm talking to you all earlier on. Moving next, and we also do understand that some patients that we have are actually on tracheostomy. So we are still allowed to shower them, but of course we have to learn how to protect the trachea. Um, in the commercial, we do have some cover-up shower collar that is shown here. Okay, but we do understand that some of it is actually not very accessible. So in fact, for some of my colleagues, we actually explore different ways of taping up to protect the trachea during shower by having large plastic bag and alcohol to tape around the neck, and to make sure that all these are well covered up for patients during a shower. Okay, so this is how it looks like. Moving on to sitting positioning is a very important part for patient MND, because we all know that as disease progression, they actually tend to lose their mobility towards the later stage. Okay, so at the very early stage, the wheelchair prescription tends to be an aid for energy conservation, especially they can't walk very far, very long. But we do understand that the dependency of the wheelchair actually increases along the way. So it's actually very important for us to get a proper assessment of the sitting and positioning of the wheelchair to actually prevent further discomfort, muscle aching. And what we do is actually we will look in terms of their sitting assessment, whereby for patient MMD, what is important to us is we actually need to get the right wheelchair. How do we define right wheelchair? Okay, we actually need to make sure that the seat width, the hip width is appropriate. We try not to give very small patients with a very big wheelchair, because a wrong fit of the seat width, right, actually cause more possible body aching that they are having because they are not sitting rightly. Okay, so we need to look in terms of the seat width by looking at the hip width of the person. Okay, the next important thing that we need to see for the patient MMD is actually the seat depth, which is the number B. Seat depth is how deep the seat should be, especially if you have a very tall patient. We need to make sure we cater more seat depth required. And also we need to look at in terms of the the seat height of the chair. So these are the things that we are looking at, especially we all know patients with MMD, they will actually lost their trunk control as disease progression. So we have to make sure that the height of the seat backrest is sufficient to support the trunk. So these are the three key things that we need to look at for a patient with MMD. So we all know that as MND progresses, the person reduced ability to sit upright against gravity and will need to adjust the position accordingly. So a proper sitting position is actually very important, very crucial in providing support to maximize function and minimize the risk of contraction and big pressure sore. So we will look in terms of having a wheelchair with a head support, maybe a truncal support, whether they need additional support on top of the existing wheelchair so that they are able to have a more upright position to engage in tasks. We don't want them to flop to certain side as well. Do they need to have a more support for their arm position when they are eating in sitting, and whether this wheelchair has to be a reclining features or can it be a tilt in space features, so on and so forth, and should this wheelchair be a motorized and manual wheelchair. So this is some of the equipments that we are looking at. To be honest, I have no answer in terms of what exactly fits patient MMD because their needs are very, very different. So some patients can fit in a tilt in space wheelchair like that is on the left side of the screen. Some patients will with trachea might feel better in a reclining wheelchair. So again, it's on the call is on them. So this is just a base thing, the basic things we are looking at. But most importantly, we actually need to get the patient to fit onto it, try it, to make sure that they are comfortable before we prescribe. So some of the consideration that we need to have when we are suggesting for wheelchair is we have to understand whether what is this wheelchair for exactly, what are the activities has to be done on the wheelchair. Is it an indoor and is it for the outdoor, and will the patient lie supine or will a tilt in space wheelchair do the job, and what are the other symptoms that the patient have. Do they tend to have a postural hypertension? If they do have it, what kind of position helps to stabilize the pressure better, whether they have whether currently they are having any pressure sore in sitting upright, and what are the features is important for a patient on the wheelchair. And of course, at the disease progression, we also have to understand that the current wheelchair we are prescribing, is it able to allowing them to use in the future, or we they need to switch a wheelchair. So these are all the things we need to think through and also check back with the patients before you do any prescription. But like what I said in the earlier slide, it's actually very important for us to get the patient to sit on the wheelchair to feel it before getting them to purchase, because after all, wheelchair is not a very cheap item as well. So these are some of the wheelchair accessories that we are looking at. I think the one of the favorites I have is actually the head support over here, because this actually help to support it is just additional features that is not that expensive that can attach on a normal wheelchair for patient with a fairly good trunk but poor neck. So it actually helps me to actually keep on tapping onto their current wheelchairs. Okay, we are also looking at some of the chest support that they are having to see whether to actually help them to secure upright. But of course, if some of the family members are able to afford more, a back support like a J cushion will be essential to actually allow a better lateral support when they are in sitting. Okay, so this is the arm support that we are talking previously, so that the arm will not flip off from the armrest. And so some of the patient might need a leg harness to actually secure the legs so that they will not flop up from in sitting position. Okay, and we also work with closely with the speech therapists to see whether there's a need to have any mounts on the wheelchair so that they can fit their AAC, whether there's the need for a lap table tray on the wheelchair so that the patient is able to put their things, engage their activities on the wheelchair. Also, they can use it to put their ventilator. Okay, and also having a ventilator tray on the back of the wheelchair, and also a tube holder as well if they are on ventilator. So tube holder help to secure the tube in a better position while they are on the move. Now I'll move on to pressure sore prevention, because after settling the wheelchairs, the next thing that we have to look into is actually the pressure sore, because reduce in mobility tends to increase the risk of developing pressure sore because our patient hardly move. Okay, and some of the basic risk factor on pressure sore we all know is reduced overall mobility. The next thing is actually having a poor inadequate sitting system. Okay, and also we all know that when patients is more dependent, family member will shift them more. So there's a lot of shearing force over the buttock, especially if they tend to lose weight, they get more bony. All these are high risk area that we are looking at. Okay, and also they are not eating very well. So reduce nutrition intake actually also put a patient at risk of having a pressure sore. So as a OT, some of the management that we have in the clinic and also at the home visit level, we actually do pressure mapping and assessment of the patient. If let's say the patient already have a pressure sore, so we might want to pressure map to actually see what areas have a higher risk of pressure sore and which particular cushion can help reduce this pressure areas more. Okay, and also we might look in terms of prescribing the trunk support better. Okay, so that there is reduced loading onto the bottom. Okay, and also prescription of pressure relief cushion. Of course, we also educate family members how to do pressure relief techniques in sitting or and lying as well, and also the regime. So in a nutshell, if we are talking about 1 hour of sitting, right? We are looking at 60 seconds of pressure relieving. So if the patient is sitting for 1 hour, we actually have to we actually help them with pressure relief to change their position for a good 60 seconds. So, okay, so this is the golden rule that we are looking at. Okay, so these are some of the available cushion that is in the market. It can be just a normal foam cushion, a cushion in honeycomb. Okay, why is it called honeycomb? Because the inner layer of the whole cushion looks like honeycomb. Okay, and this type of cushion tends to be more stable for patients with poor trunk. So our patients group actually tends to benefit this better because of the stability support. Okay, we also have those cushion that's hybrid, whereby there's a foam plus a gel. Okay, also there's some of the cushion have a contour features, and also last but not least, a very well-known brand will be Roho. Roho is actually an air pressure relief cushion. Okay, but most of our patients with MND tends not to work very well with Roho because firstly they are not very stable in sitting, and also they are looking at different areas also. As a disease progression, the other things that we are looking at is a hospital bed and also a pressure relief mattress also. That these are the things that we will normally prescribe for patients. whether they can relocate the washing machine, and also to see whether they can remove the curb or building a ramp so that a commode can be pushed in. But of course, when a commode push in, it might not have enough turning radius. So what are the things that we can do to actually help the patient to go to toilet easier as well, and also reduce the carer burden in carrying the patient into the toilet directly? We actually suggest that it is very important for us to do the home assessment as early as possible in view of the progression. So for me, when I do a home visit for patients, right, I will do a now and then recommendation. I'll be telling patient at this point, this is the things that you need to do to prevent any fall. But while doing this, we need to look for resources to help to build a ramp, or you need to get contractor to come and hack away the curbs as well, because all this take time. It's not some all these are not something that at the call, you settle it at a go. We will actually do some home modification suggestion, looking at in terms of the environmental control of a person, looking at in terms of whether there is a need to install a grab bar, a ramp for wheelchair accessibility. For patients home with a stairs, we have to explore whether do they have an additional room downstairs for patients, or person with MND to live in, or is there a way to actually bring the patient up to the second level by using a stair lift or a chair lift? Yeah. And also looking at whether our patients can open the door of the handle. Is there a need to actually use an enlarged door handle so that they don't need to grip so tightly? Whether there's a need to have a key turner, a knob turner to help them to open a door easily. And of course, some of the things, there are other things that we need to look at it when we are looking at ventilator usage also. Other things that you look at is after you set up that home environment, you have to look in terms of whether there's actually any caregiving space for the carer, and also does this space created does it cause any ergonomic issue in caregiver when they are doing their caregiving? Okay, and we need to look at the placement of all the consumables or equipment. I think this is very important when we are doing with patient with home ventilator. Okay, and also whether there's a possible area for family interaction and patient privacy. So in Singapore, because our housing is actually very small, so some of the family member will say that, oh, never mind, I can't move anything in the bedroom, I will put a hospital bed in the living room. But as an OT, well, this is something that is feasible, but we have to look in terms of privacy. So it's actually not possible for us to actually get the patient change diaper in a very open public in the living room, right? So we actually have to suggest family members, do you want to do some curtain line to actually create a curtain to draw so that this person has some private moment and resting, okay, while they are still spending some time with you in other part of the days. Okay, these are the things that we will consider and suggest. Okay, so some of the keynote with person with ventilator, right? I think in all rooms that the patient that will spend time in, we have to make sure that there's always a separate power socket for ventilator. We try not to, we do not suggest them to actually do extension to share all the power in the same socket. Okay, and we also need to look at the possible infection by having to see whether there's a lot of pets at home. Is it very dusty? Is there any fumes from the outdoor traffic as well? So these are the things that we look at and suggest accordingly. Okay, for accessibility, like what I said earlier on, we're looking at removal of curbs. If not, we are looking at having a portable ramps, okay, or a portable ramp that is telescopic that can be easily brought out with the family members, and also the stair lift and chair lift system. And this is some of the outdoor ramp installation that we can consider. So OT, we actually look at, like earlier on I mentioned, one of the things that we do is actually to empower caregivers. So through empowering caregivers, they are able to provide care, but as an OT, you also need to take care of our caregiver. So a proper training is needed. So we actually teach them, we actually assess their competency in their competency assisting their ADL, use the assistive devices. because we don't want them to get injured along the way while providing care. Okay, we actually will look at the different possible transfer method that we can teach them to help them with those patient that is more dependent, non-ambulating, and we also do training in terms of their transfer techniques, usage of equipments, okay, and also teach them in terms of their proper safe manual handling techniques also. Okay, so it's actually when we all know when a person with MND is more dependent, right? It's actually very important for us to actually educate carers on how to handle them properly to prevent for injury for either one of them. Okay, and the equipment that we suggest normally will be determined by the carer themselves, how strong they are, and also our client or patient in MMD, how dependent they are in terms of their function level. So is there a need to use a transfer board or a transfer belt or hoist? Yeah, this is the things that we consider. Okay, so this is just an illustration of what is a normal transfer that we are looking at. So normally, because Zoom, I can't really demonstrate very well to you guys. So this is some of the picture illustration. So when we want to do a transfer of patients, right? Very importantly is actually we have to stand in front of patient with our back straight and also a knee bend. Okay, knowing that the lower limb of the person is actually weak or unsteady, it's actually very important for us to use our leg to block the knee for transfer. So make sure that the patient, if able to, they get them to hold on to the armrest. If unable, just make sure their hands are on their chest area, and we will actually put our hand under the patient's shoulder blade, onto the shoulder blade, and also another hand onto under their buttock to have a firm grip before we just do a pivot transfer. So normally we don't actually carry the patient, we actually will just gently glide the patient to the other surface. So this is just a quick illustration on this. Okay, but we all know that some of the patient might not be able to hold as per what we suggested, so we might just ask them to actually hug the patient tightly by gripping their own hand behind the patient rib cage, like what is shown here, and get the patient to lean forward before we slowly turn the patient onto the chair. So we also do two-person transfer whereby we get a second helper to help. So the first helper actually does what was mentioned earlier on. The second helper actually assists the patient from the back by helping to arrange the wheelchair close to the bed and also guiding the patient buttock into the wheelchair. That's the job of the second helper. Okay, this is how it was actually being seen. It illustrates on the photos. If you want to have more information how to do a transfer, or you want to share information with the caregivers during your practice, right? You can actually just scan this two QR code, because this two QR code have available information on how to do a transfer, and you actually can pass it to the family members as well. Okay, so these are credits to Agency of Integrated Care in Singapore. This is the body mechanics booklet that they have. And also in our Tan Tock Seng Health Library, the physio actually have a booklet on function activities on how to transfer patient. So you can take some resources from them as well. Okay, so these are the equipment that I mentioned earlier on, a hoist, a transfer board, and also a transfer belt. So it is actually very important for us to check on the safety of the person with MND and also carer in their ADL tasks and also usage of equipment. If your organization do have an occupational therapist, you can actually refer them to actually look at the function equipment if there's actually changes in the function of the person, and also whether there's more needs of equipment required. So let me share with you some of the aspects that we do in nursing. As I mentioned, some of my colleagues actually do driving. So a person with MMD, they are still able to drive if doctors actually certify them fit to drive. But of course, we actually suggest them to actually have a proper driving assessment to assess their functional ability, because sometimes they might need an additional modification of the vehicles in order to actually drive safely Okay, it can be things like having a sternum knot, or having an alternate hand and foot control instead, or whether do they need a swivel chair to transfer in the vehicles, and whether this vehicle is able to store a wheelchair or mobility aid as well. So these are the things that we are looking at. So, but we also need to look at um, their workplace as well, because we all know that some of our patient MMD are in their prime age whereby they are still possibly working. So it's actually very important for us as a professional to, of course, with the consent with the person with MMD, right? We actually need to have some words with the employer to see whether how we can modify the job to help them to continue to stay in work. Okay, so the management that we have, we can actually do a workplace assessment to assess what are the things the patient need to do at work. With that, we are able to give some suggestion on how we can modify a task and also the job accommodation. So previously I do have a patient that with MMD, she was actually working as a statutory in a as admin assistant in a company whereby she needs to actually help to deliver files to different location in the office. However, she find it very difficult to actually carry all those files. So I actually suggested her to actually consider to actually have some trolley whereby she put all the files for her to push. But the size of trolley has to be considered because she does have difficulty in maneuver, especially when we look at trolleys in the office tends to have smaller wheels, so it's very difficult to navigate it. So we had to look at appropriate tools for her to use, and that trolley that she's using to deliver things can be a form of support for her while she's walking as well. So these are the small little things that we can suggest and make changes to make work easier for patients. Okay, we also will be looking in terms of equipment prescription, whether do the patient needs a writing pad instead of a keyboard, or whether it should this keyboard to be those one-handed keyboard, or should the mouse be controlled by the foot itself. So these are the things that we are looking at. Also to negotiate with the employer whether should there be a need or changing working hours, because sometimes it can be quite tough to actually travel in peak hours. So having to work later and end later, would it be more helpful for the patients, or whether is there an option for working from home? So these are all the things that we will do for patients. So that is the end for my sharing today.
Okay, so I was invited today to have to share about speech and communication and what you can do, and I thought I would do it in a manner that hopefully we'll be able to by the end of today understand what normal speech and swallowing physiology consists of, understand how MND can affect speech and swallowing. Because quite a few of my patients with MND actually have tracheostomy, or they require the use of mechanical ventilation. So I thought also maybe how having a tracheostomy and the use of mechanical ventilation can affect speech and swallowing. The role of the ST, of course, because that's what I do. And towards the end, just some sharing of some communication options and why or how the impact on speech and swallowing can actually affect a person's quality of life. To produce speech, we actually need various subsystems such as the respiratory system, the phonatory system, which is where your voice box lives, your articulatory systems, which is your lips, your tongue, even your palate, resonance, as well as prosody. So speech produced by individuals can be affected if, let's say, one or more of these subsystems are actually affected. So normal intratracheal pressure during speech is actually about 5 to 10 cm H2O, and normal speech airflow actually ranges anywhere between 13 to 18 liters per minute. And to get really technical here, because later on we'll be talking about some ventilation setting. We'll be talking about mechanical ventilation. The subglottic pressure needed is actually about 2 cm H2O for adequate voicing. Okay, so you can imagine that if, let's say, you were you had a tracheostomy, or if you're on mechanical ventilation, then all these pressures and systems can actually be affected. And of course, if you've got a neuromuscular disease like what MND is, then certain subsystems, because of muscle weakness, can also then be affected. So in swallowing, so you've got basically 3 phases of swallowing, right? So you've got the oral, the pharyngeal, and the esophageal. During the oral phase, you have the food in your mouth, food or fluid in your mouth. You hold it there, you manipulate it if you need to, you chew on it if it's a food bolus, and then all this while as you're doing this, you would still continue to breathe. But as soon as you trigger the swallow and you enter the pharyngeal phase, you actually stop swallowing for a moment. You stop breathing for a moment. You don't stop swallowing. You stop breathing for a moment, and you have a period of apnea where the airway is actually blocked off, and the food then travels towards your food pipe or your esophagus. And in the third phase, where your food pipe opens and the food travels down through your esophagus, you then can resume breathing again. So yet again, you can see how these differences in pressure systems. So how the airway is open, then the airway has to close, and the airway has to open up again. Having a tracheostomy or being on mechanical ventilation can then affect how this system can work overall. So let's talk a little bit about swallowing in MND. So swallowing difficulties or dysphagia is actually a common symptom of MND, especially if bulbar muscles are involved. So an estimated about 70 to 80% of people with ALS have dysphagia, and usually it's the oral phase that's affected first, followed by the pharyngeal phase. So why are we so why do we even place an emphasis on swallowing? So having a swallowing impairment or dysphagia actually can affect a few things. So like I think Huixin alluded to, having a swallowing problem, if you don't get adequate nutrition, it will lead to muscle mass loss, it will lead to weight loss, and then obviously it can actually contribute to worsening pressure sores. And then, you and I know food is a very important and integral part of our lives, not just to eat to get nutrition, but also for quality of life. It's an aspect where we you get around the table, you makan with your family, you makan with your friends, So having a swallowing problem or a dysphagia can actually have a significant impact on one's social interactions and their participation in certain activities. So for example, if you had a swallowing problem, you may not be so keen to go and makan with your friends or to go and eat out with them, just because, you might feel a bit self-conscious about the way that you're eating. Or if you've seen an ST and your ST says you must have, pureed diet or, something like that, and you'd be a bit, you might find that food choices are then difficult to access. So then, again, you don't really want to be hanging out with your friends when everybody's eating, char kway teow, and you are the only one eating your pureed porridge, for example. Yeah. So then the quality of life aspect and your participation in certain activities would probably then be affected. So and so some other areas where having a swallowing problem will then have an impact is also the risk of aspiration pneumonia. So if you're not able to swallow safely, and food and fluids are entering your airway, bringing bacteria into your airway, blocking your airways, and thereby your lungs, there is a chance that aspiration pneumonia can occur, and this will then have an impact on how like you'll need a hospital admission, and you're going to be very unwell. So this is also a point of consideration as to how having a dysphagia can affect the person's life. So, it was seen that actually having a clinical bedside assessment, which I will delve a little bit more into later, is not really always that sensitive to be picking up subclinical dysphagia. So we can't just rely on looking at how a person eats and drinks. And so the speech therapist has actually a few things in their bag of tricks to find out whether how bad the dysphagia is, how safe the swallowing is, and then we kind of pull that out in our interactions and in our interventions with the patient, just to make sure that, what we're seeing is actually what is happening, and we're not overconfident about their ability to swallow safely. So some signs of dysphagia could include, unexpected, unintentional loss of weight. So, the person could be eating and eating and eating, but they're just not gaining or maintaining their weight as they should. Some signs that, they're having problems would be loss of food and fluids out the mouth. If they put food in the mouth and they take a very, very long time to swallow, so having a delayed swallow is also a sign of dysphagia. Having leftovers or residue inside the mouth post swallow, and of course, your go-to, which is your coughing and choking when eating or drinking. So these are some signs that you can actually look out for and ask patients and their next of kin, do you experience these signs? And there are also some screening tools available that you can use for self-reported, for patient-reported measures, so that it's something that you can actually track across sessions when you are seeing patients with MND. So, like mentioned before, speech is actually made up of these various subsystems, and any weakness in any of these systems can actually result in dysarthria. So dysarthria is, in very layman's terms, it would be like slurred speech or difficulties with speech. And roughly about 30% of people with ALS actually have dysarthria, and this increases to about 80% across the span of the disease, right? So there has been research on the longitudinal decline of speech intelligibility in ALS, and it does show that the rate of intelligibility decline is actually not consistent during the disease progression. So there are usually two phases observed, where in the early phase, intelligibility can actually be really good. If let's say the subsystems are not significantly impacted, and it will actually decline quite slowly. But in the later phases, it can actually shows quite a sharp decline, and the loss of speech can happen in a short span of time. So this is usually one area that as speech therapists we do struggle with, because usually in the early phases, when the person and the family are still trying to cope with the news of this horrible condition or this diagnosis that has been flung upon them, how much do you broach? Next time you won't be able to talk, or next time you won't be able to eat. It's actually one of these things that we have to pace with the person and their family. But for as much as possible, we definitely try and advocate for early introduction and intervention with regards to alternative and augmentative communication, just because we know how much the speech can actually decline, and maybe during the later phases how quickly it can decline, where then some options for communication devices may then not be suitable anymore. There was a recent study that I just had a look at. So Stegman and colleagues actually tracked articulatory precision and the rate of speech in patients with ALS. They compared it with normals, and they actually tracked it over a period of 3 to 9 months. So what they found was actually patients with bulbar onset symptoms have this sharp decline in how clear their speech is, as compared to, so they compared two, they took two parameters. One was how clear the speech was, and another one was the rate of speech, so how fast and the person is able to speak. So they did find that those with bulbar onset symptoms actually have a sharper decline in how clear the speech is, whereas those with non-bulbar onsets actually showed a relatively less steep decline. So this is one of the things that we've been trying to track as speech therapists, across sessions, to try and have a look at how clear certain our patient's speech is, in order to track how fast the progression is. And so this is helpful for us, because then we can have an idea, because I'm sure due to resource limitations, it's not that we can see these patients every week or every other week in order to track their progress. But when we see them, every 2 to 3 months, we do try and take a speech sample so that we can track, from time point to time point, what their speech intelligibility is like, and then be able to kind of prognosticate if, let's say, we need to, push for some alternative communication options. How much do we then push and pace with the patient and encourage them to take these options up. Okay, so just quickly talking about the impact of tracheostomy on speech. So for patients on a tracheostomy, actually the setting of the tracheostomy tube makes a huge difference as to whether verbal speech is possible or not. In the picture on the left, my left, this one, okay, you can see that the tracheostomy cuff is inflated and there isn't any fenestration or any holes in the tracheostomy tube. And so because of that, the airflow is actually directed in and out of the tracheostomy tube. There is no airflow up past the vocal cords. And because of that, speech is not possible. Okay, so for speech to occur, remember that the subglottic pressure needs to be at least 2 cm H2O, and there needs to be airflow, in order for speech to occur. So if the patient has a tracheostomy tube and the cuff is inflated, there's no air going up towards the vocal cords, through the mouth, through the nose, then speech is not possible. But communication is still possible. Okay, so we'll talk about that a little bit later, but speech, unfortunately, will not be possible. So then, if you look at the picture on the right, my right, you can see that the setting is slightly different. I know the arrows are a bit confusing, but basically the arrows are there to show how the air flows. So the air can actually flow in through the tracheostomy tube. The cuff is deflated, it will go into the lungs, and as you speak and as the person expires, right, some air will actually go out through the tracheostomy tube, which is fine, but there will also be some airflow that will be directed up towards past the vocal cords, into the mouth and nose, and there the person can then manipulate this airflow and be able to produce speech. Okay, so if your patient is able to tolerate cuff deflation, right, with or without the fenestration in the tube, in the tracheostomy tube, verbal communication is then is an option for them, right, with or without the use of a ventilator. A note though is that the size of the tracheostomy tube can actually make a difference to how successful or how easy it is for the person to produce speech. So this is something that we will, because if you think about it, the size of your trachea, right, plus you've got your size of the trachea, and if, let's say, the size of your tracheostomy tube just nice fills the entire area of your trachea, then there will not be airflow around the tracheostomy tube, and then because there's no airflow, then speech becomes more challenging, even though your patient can tolerate cuff deflation. Okay, so this is just something to note, because sometimes what happens is, we get stuck when the person can tolerate cuff deflation but yet not be able to produce speech. Then this is something that we need to talk to the medical team about. Is it possible for us to then change the size of the tracheostomy tube in order to facilitate that airflow and then encourage speech? All right, so the role of the ST. Coming back to the role of the ST, so we assess and manage swallowing and communication issues. There are quite a few things that we do think about. I think, as David mentioned, I see patients across the continuum of care. So patients who are in the ICU versus patients who are in the general ward. And then as they transit back to home, the setting in which they are being seen, and also considering the time point of where they are in their disease progression is also really important in considering how you would manage a patient with swallowing and communication issues because of ALS or MND. Of course, other factors that we do consider would be things like mood, behavior, what this person's communication needs are, who their partners are. So sometimes in cases where you've got an elderly patient who can only speak Mandarin or a dialect, right? But their communication partner is a Indonesian helper, for example, then we need to consider the dynamics of that and what would then be most suitable in terms of intervention. And of course, not to forget what the patient's goals are. So I think as Huixin mentioned as well, we do see patients who are at different time points in their lives when they get diagnosed with ALS or MND, and it really affects what we do and how we would approach, recommending certain things depending on what their existing goals are, and how we can then move forward together to be able to meet those goals. So our role in looking in swallowing is actually, looking at the medical history, looking at what the presenting features are, and getting a report of what the issues would be, looking at their cranial nerves, like mentioned just now, whether there is a tracheostomy or not. So remembering back to the difference in pressure systems with the tracheostomy in place, which I'll touch on briefly later on. And also remembering that you can't just look at the patient and then be able to assess, okay, this is safe or this is not safe for eating and drinking. So we do food and fluid trials using instrumental assessments as well as a modified Evans blue dye test. So I won't really go much into detail in terms of this swallowing assessment, because I think the main aim today, we're trying to focus a bit more on the communication aspect. But if anybody has any questions about these assessments, please feel free to bring that up a little bit later and I'll be happy to address them. Okay, so we get to the communication part. So like mentioned as well, the presence of the tracheostomy is really important, especially if it has been newly inserted, right? And how that then affects the person's ability to speak is also going to be affected. The presence of NIV, which is non-invasive ventilation, versus having a mechanical ventilator attached to a tracheostomy is also something that we would take into consideration. And the dependence. So if, let's say, the person has respiratory weakness, but is maybe early days, which means they're not fully dependent on the non-invasive ventilator, or having a mechanical ventilator hooked up to the tracheostomy all the time, this then gives us an option to explore certain communication options, so which I will touch on later, which can then allow easier speech. We will also look at the physical and motor condition of the patient. So this includes things like, limb dexterity or motor function. So why we look at limb dexterity is really looking at what Huixin alluded to, which is access. So for some communication devices and options, sometimes you need access to those devices. And by looking at how well, they can, point, for example, how well they gesture, for example, we can then have an idea of what would then be suitable. And of course, we will work very, very closely with our OT colleagues to get a better sense of what are the options available in terms of access to communication devices. Looking at oromotor function is important. So like looking at your cranial nerve function is really important because like mentioned, if you have a person with bulbar signs or with bulbar features early on, then you would imagine that even if the person is not on a tracheostomy or not on invasive and any kind of ventilation dependence, their speech is already going to start showing signs that it may not be the most reliable method for communication. So then that then also tells us, we may then need to consider other options. Yeah. Vision is also something that we do look at because the new hype thing that is, happening in my department over the last, 3 to 5 years is actually the use of an eye tracking device. So not that with poor vision. So with poor vision or with, the difficulties in seeing, images, this option can, may then not be suitable. and you may then need to rely on auditory input rather than visual input, which is the mainstay of of using this eye tracking device. So vision is also really important, and things like maybe do they need glasses to actually improve on their ability to see, near, far, do they do better with pictures versus do they they need words? This will all then come into play when we are assessing the next part, which is the cognitive linguistic part. So understanding what their literacy levels are. So I can say that maybe in the last, 5 to 10 years, of practice, we are actually seeing, we are seeing a shift from patients who are a lot older, less literate, and therefore having more limited options to what alternative communication devices that we can offer to them, to now where we do see younger patients coming on board. The demographics and the population characteristics have actually changed slightly, such that we have a group of younger patients who are literate, English, Mandarin, maybe bilingual. Then the communication options that are available to this group of people is actually a lot wider as compared to someone who's a bit older, who may not be as literate, and maybe in terms of language may not know English, for example. So then there is this difference, and this is something that we do need to take into consideration when we are doing this assessment. So and the language of patient and carer. So like mentioned just now, it is, is there a match or is there a mismatch? Elderly gentleman who can only speak a dialect versus, the main communication partner is maybe someone, a young helper who can only speak maybe Bahasa, Indonesian or something like that. So there is, so when there is that gap, then we also need to consider, how do we make it such, how do we offer a solution such that both the communication partners are able to benefit from this communication exchange. And last but not least, the access, which was mentioned a little bit earlier in terms of the physical and motor. Another thing about access is also, of course, I think as Huixin mentioned just now, some of the options that we do have available are quite pricey. Money is always an issue. So fortunately in Singapore, there is what we call an assistive technology fund, which we do tap into for patients who need assistive technology. So if, let's say, there is something that our patients need in order to fulfill certain roles in their life. So for example, to be able to do work in order to be more independent in their communication, we will then apply for this funding for them. So this is also one point of access, right? Like if you no money, then no talk, which is quite sad. Yeah. So as much as possible, we try and explore options for our patients. And yeah, so yeah, I just thought I put that up as well. Okay, so just delving a little bit more into some of the communication options available to our patients. So this is so now you think back to when you're on a tracheostomy, okay, and you can deflate the cuff. So as mentioned, right, you can actually have airflow up towards the mouth, but some of the air also then comes out through the tracheostomy tube. So these are two ways in which you can stop the air from coming out from the tracheostomy tube and directing it all up towards your mouth and your throat and your mouth. And this will actually give you a slightly louder voice. It will make it less effortful when you are speaking. So one of the ways in which we do that is if, let's say, you don't have access to a speaking valve, which is actually a one-way valve, you can actually just use your finger or your thumb. If, let's say, the person still has a fairly good dexterity, you can actually teach your patient to just cover it up when they speak. So on inhalation, you open, and then on exhalation, you just cover and press. And this will actually just force the air up towards your mouth and your throat, and you'll be able to get clearer and louder speech. If you have access to a speaking valve, and there are two types of speaking valves here that I've shown. The green valve is actually one that is an inline speaking valve, and it can be used with when the person is on a ventilator. And the white one that you can see is a shyly speaking valve, which basically means that it's not one that you can use when you're on a ventilator. But if you need supplemental oxygen, you actually can still provide that supplemental oxygen while you are using the speaking valve. So basically, a speaking valve is a one-way valve where when you put it on, basically air can still enter the tracheostomy, and but when you speak, there is actually pressure, the subglottic pressure closes the one-way valve, and the air then gets redirected up towards the mouth and the throat to produce speech. Okay, so these are options that you will use when your cuff is there, but able to tolerate cuff deflation. If you have a cuff, if you have a tracheostomy with a cuff, but you cannot tolerate cuff deflation for whatever reason, maybe your ventilatory needs are very high, maybe you've got a lot like excessive oropharyngeal secretions, and it is just dangerous for the cuff to be deflated, then using the method of above cuff vocalization can also help you to produce speech. So if you have a look at the two pictures below, basically the type of tracheostomy then plays a very big part. You need to have a tracheostomy with an above cuff aspiration line. So the suction aid is one of those that has this above cuff aspiration line. And what you do is the main function of the above cuff aspiration line is actually to remove secretions above the cuff. But if you think about it, if you can remove things from above the cuff, you can also introduce things above the cuff. So that is what we do with above cuff vocalization. So there are some protocols in place, and there have been studies, coming out, I think 2015, 2016, from then on, with more interest in looking at this option for patients who cannot tolerate cuff deflation. And it's actually been noted to be quite successful. But there are some contraindications. So for example, if let's say you have a newly inserted tracheostomy, you shouldn't be doing this above cuff vocalization within 48 hours. Just because it just needs a bit of time to the tracheotomy needs to settle, right? And you don't want to actually be introducing air in between your skin and your muscles. There have also been incidents where patients have subcutaneous emphysema because of the use of above cuff vocalization. So we need to actually approach this with quite a bit of caution. And if let's say this is something that you are keen to explore, to implement at where you're in your setting, I would actually highly encourage you to read up on some of the papers, especially from the Austin Health TRAMS group. They have quite good resources on how to conduct above cuff vocalization. They have a whole list of contraindications that you need to be aware of. So this is something that I will highly encourage you to work with a speech therapist in your area or in your setting to get this going, because it can benefit a group of patients who cannot tolerate cuff deflation, but are raring to go in terms of their communication, and they're really trying to get speech out. It's just that unfortunately maybe their lungs are not ready at this point in time. Yeah, so that's above cuff vocalization, and it's really interesting, and I'm still trying to gather more patients who are suitable to try this out on, because it is still quite new where we are in Tan Tock Seng. But yeah, so it's something that's definitely worth exploring. Okay, so another communication option that will be available to a person who's raring to go is the use of an electrolarynx. So I'm just gonna play this video for you. You will probably see that in this picture, this person has a laryngectomy, so where the larynx has actually been removed. But this can be used for patients on a tracheostomy as well. Okay, so I'll just play the video first and then I'll explain what this is. Okay, so if you can hear her, I would imagine that the first word that would come to your mind in terms of describing how she sounds, right, will probably be robotic. You sound like a robot. Yeah. So basically what's happening with an electrolarynx is, instead of using the natural vibrations of the vocal cord, where when air passes through it to produce sound, okay, we are actually replacing those vibrations by using a handheld vibrator, if you can call it that. So an electrolarynx produces vibrations, and when you put it against your neck or even your mouth, right, or your cheek, it produces vibrations such that you can actually use those vibrations and use that sound to shape speech sounds and then create speech. Yeah. So, but I must say, in all my time working as a ST, right, not very many people will adopt this because it just sounds unnatural, and it's and that one device is, I heard, quite expensive. So not many people I know have actually taken this on board, but it is still an option, especially in the short term, because we've got like a device in the department. We sometimes do loan it out to patients if, let's say, they do need it for the short term while they're waiting for certain things to settle and they still want to communicate. They don't mind having this robotic sounding voice. It definitely then is an option for them to consider. So moving into other communication options. So we have a whole range of what we call alternative and augmentative communication devices. So AAC for short, because it is a huge mouthful, I'll be using AAC, okay, instead of alternative and augmentative communication devices. So basically AAC, if you look at alternative, it means that if you can't speak, you use a different, or if you're finding it hard to communicate via speech, then we find you an alternative way. Something augmentative would be something to supplement what you are already doing. So for example, if let's say, so an example would be, if let's say you are talking to an audience that is in a huge, if you're giving a talk, right, to an audience that's in a huge ballroom, having a microphone is actually an augmentative device that helps you to augment what you can do, but be able to do a function that maybe would be challenging with just your voice. So it amplifies your voice and then it allows you to communicate with people at the back of the room. But something alternative would be, you typing and then putting something up on the screen instead of having to talk to send a message to someone to the back of the room. So that's the difference basically between what is alternative and what is considered augmentative. And so some of these, so some of the options as listed below would be seen as forms of AAC. So if let's say you have your cuff inflated and you can't verbalize, then mouthing would be an option, right, to get your message across. Writing would also be an option to get your message across without having to speak. Typing, typing something out and then having with technology nowadays, it's not just about typing and then somebody having to read what you have typed, but there are text-to-speech apps that you can type into and then it will read out what you have typed. Gestures, so gestures can help to augment what you are trying to say. If let's say it's not so clear, you do like, I want a drink, and someone will probably be able to understand you a little bit better. We also use things like picture charts and books. So as seen at the bottom corner of the page, this would be an example of what a picture chart could look like. Or if let's say it's you've got a compilation of all these charts, we can actually make it into a book such that it is more accessible for various parts of your daily of the patient's daily living. We also have, like what I mentioned earlier, using eye gaze methods to communicate. So I'll be showing you a video of the use of this eye gaze device. So this is an E-Tran board, and basically an E-Tran board just means eye transfer board. Okay, if you can see, this E-Tran is, this board is actually transparent, and it's got a little hole in the center, which basically is where you would put your face, and you would face the person that you are talking to directly. So the reason why we do that is because, and the reason why we keep it clear is because we need to see where the person's eyes are moving, and this helps us understand the selection that they're making. Okay, so I'm just going to stop share my screen for a moment, and then I'll go into this YouTube video that I want to show you. So basically, I'll just walk you through as she is doing it. Okay, there are some subtitles. So what she's doing first, and what we would usually ask our patients to do, is look at the block, meaning where the letter happens, right? So you can see, so basically what you are seeing, which is what we are seeing on the screen, is a mirror image of what the person is seeing on the other side. Okay, and if you can see, the letters are actually printed in a different color, right? So you see that A is green, B is yellow, and you can also see dots, colored dots in the different quadrants of this board. Okay, so what this lady is doing is, firstly, she's looking at the block of letters. Okay, so once we confirm the block that she has chosen, okay, once we've got the letter, then we ask them to look at the color. So then the color determines which letter it is in that block. Yep. Yep. And you can see that this lady does blinking, I think, to confirm whether, you know, that is the right letter selected or not. And you can see that it really requires the listener, which is the lady in blue, to keep track of all the letters that have been spelled out. So as you can see, it's effortful for both the speaker and the listener, because it actually requires a lot of time. It requires quite a bit of practice. And if, let's say, you are not well versed in it, you might find that it is challenging. Yeah, so as shared, it would be challenging because you do need your communication partner or your listener to go through a period of training in order to be fairly familiar with how to work this eye transfer board. And this is for a person who is literate, meaning a person who can spell, right? If, let's say, for whatever reason, you know, you have a person who can't spell, or maybe, you know, only knows Mandarin but doesn't know like Hanyu Ping, meaning like how you would use Romanized letters to spell out the sounds of Chinese words, then this can also be an option, which is the picture on the left, where you can see symbols. So you can actually set up an E-Tran board such that there are symbols as well. And you can still use this board fairly successfully with symbols. So we have created, so at Tan Tock Seng, we usually don't do it such that it is on such a bulky acrylic board. We do it such that we cut out all these, you know, little pictures, and then we laminate it using a clear sheet. So this is how we kind of get around being able to create more of these options. So for example, you can imagine if, let's say, the person requires symbols, right, or pictures to communicate their needs, then it's not just as simple as one sheet will suffice. You probably need multiple sheets, and then you have various pictures on each sheet, and then and to be able to create that, we can't really create acrylic boards for every single sheet. So we have found it more efficient to use, you cut it out and then you put like it on an A4 or an A3 laminated pouch, and then we just laminate it through, and it works fairly well. So so that's what we've been doing to get around the bulkiness of this eTrend boards. Another option, so that would be considered a fairly low tech option, where it doesn't involve any like complex computer systems. But this next thing that I'm going to share with you actually involves a computer system. It is high tech, obviously, because it's got technology beyond the science that I can really understand, but it works. So it's basically using cameras. It uses infrared sensors, and it tracks the like where your eye or the pupil is looking at on a screen. And it then translates using various algorithms and a lot of AI to know where your eye is looking on the screen. And it uses this, what we call eye gaze technology or eye tracking technology to make selections. So instead of using a mouse to access, like to click on certain parts of a computer system to activate certain apps, or instead of using a physical keyboard to type, you actually use your eye movements and eye gaze, meaning like they look at dwell time, how long you're staring at one thing to indicate your attention to that particular part of the screen, and then it will select based on certain parameters that you have set up. Just gonna lower the sound a little bit. So basically, I'm taking this video off the Isaac Singapore Facebook page. This video was created by one of our patients with ALS, and he's actually just showing and sharing how he uses this Tobii eye gaze device. So there's need to do calibration. You can see that there is like this little clock circle thing that gets activated when he looks at a certain part of the screen. So this is completely controlled by using eye gaze. Okay, so he's just showing you how you would calibrate something. And I'm just going to skip to part 2 because part 2 shows him typing. Okay. Yeah. So you can see the clicking, okay, and he is using his eye movements to select the letters, and you can also see that there's predictive text, a predictive text function up here, where he then, he doesn't have to type every single thing out. He can actually just select, once the word that he wants comes out. All right, I won't belabor this point, but basically it is quite cool that he's able to do this. He's really not able to. He doesn't really have function of his hands anymore. So it's really cool that he can still create such a cool video, of course with the help of his family members, but it's still awesome, that he can send a message across and it's reaching so many people by just the use of this eye gaze technology. So just wanted to just say, shout out that this is something that is helpful. Yeah. Okay. So another thing that I wanted to show you is access, right? So just now we're talking about access, and we're talking about how so Jerry uses eye gaze to access the system. This gentleman is actually using a gyroscopic mouse to access the system. So basically, a gyroscopic mouse is something where is a device where it senses the device's position in space, and it translates that into movement on the screen. So I am just going to rewind this. There's no sound to this video, but I just want to bring your attention to the person's right foot. So you can see this black device, that has been taped using micropore onto his right foot. And I would also bring your attention to the screen that we can see. And maybe if you could pay attention to what is being highlighted on the screen, that kind of shows where he's making that selection. Okay, so I'll just play it through first. So you can see the cursor also, right? You can see the cursor that's there, and if he dwells long enough on a certain spot, that's when the computer knows that this is what he's selecting. Okay, I'm going to play that again because it's really, I know it goes really fast. So this gyroscopic mouse, it's by QHA. It's a QHA Zono. And basically, it's not just, you don't just use it on the foot, right? I mean, you can use it on any part of your body that you still have good control over. Some people, you put it on their head because they have fairly good control of their head and neck, and using their head and neck movements, they can actually make selections. But for this gentleman, it was his foot that we found was, the best option for him to control more successfully. So, this is access again, like how do you access certain systems? And this is part of us finding ways to help the patients access certain systems so that they can communicate more effectively. Other types of access include things like switches. So I think this is something that Huixin did mention during her talk, and talking about, the type of switches that are suitable, how much pressure and power, which parts of the body do you do you attach these switches to, or how do you activate these switches? This is something that we would also explore with the OTs to make sure that we've got the right switch for the right patient and at the right time point as well. So these things are always continually evolving because that the disease does progress, and at certain time points, maybe certain options are suitable, but further down the road, it may not then be suitable anymore. Okay, so just to quickly talk about the impact of non-invasive ventilation on speech. So if let's say you have a patient who needs non-invasive ventilation, as you can see, there are different mask interfaces that can be used to apply this non-invasive ventilation. And if you can see, it's actually, 2 out of 3 actually affect the mouth area. So if you just have the nasal interface, then it doesn't really affect speech that significantly. But if you have one that is a full face mask, or if you have one that is an intraoral mouthpiece, then it then can affect speech intelligibility quite a bit. So we then need to see how we can get around it. Are there certain things that we can do to provide additional support, via alternative communication methods, in order to help this person communicate more effectively if, let's say, they are really fully dependent on this non-invasive ventilation. So, so just to talk a little bit about the importance of communication, I think I have talked a lot today and I have communicated a lot of things today. So we can see that communication via speech, via images, via text, is actually really important in communicating and conveying messages, right? And that's basically the aim of communication, isn't it? In no matter how or what you're communicating, the important thing is to get the message across. So I cannot emphasize enough how important communication is. And I mean, if any of you have had, a sore throat, in the last 12 months, which hopefully didn't get you, quarantined, it's hard, right? If you can't say what you want to say, you can't tell somebody, or you can't express yourself as easily as you would have, because we do take verbal communication for granted, it then becomes really challenging. Okay, but I must say, with the advent of technology and with the advances in technology, it is making it slightly easier. But that being said, there's also a price that we need to pay. So sometimes it's not just about the advances in technology, but it's also looking at what we have available to us and really just thinking outside the box and being quite innovative about what we have available to us to try and improve that level of communication between a person who has MND or any of your other patients, in fact, and the communication partners. So as mentioned before as well, it's always really hard because when is the right time to talk about, next time you will have difficulties with communication when the news of, like when your patient actually needs to grapple with the news of he's, not going to be able to walk, he's not going to be able to talk, he's not going to be able to eat. It's really tough to then, bring up this conversation about, so what do you do about it if, let's say, they're not ready. And I think another point that I wanted to kind of talk about, because, communication and QOL is talking about leaving a legacy. And sometimes it is through communication methods, by either you write something down, you put something concrete in place so that you can actually tell people your story, even when you are no longer around. How do you then leave a legacy for, for example, if you are a father with children, very young children, how do you then leave a legacy for them to still know who you are, who you were, when you're not around. So having this ability to communicate via no matter what means, right, is actually really, really important to a person with MND. And it's, and that's where we come in as speech therapists and as healthcare professionals. I don't think it's just limited to speech therapists alone, but I do think that all of us do have a part to play in trying to help this or assist this person to be able to leave some sort of legacy for when they are no longer with us. And also just looking at swallowing really quickly and QOL. So just talking about, so in the earlier slides where I mentioned, having a dysphagia and that, having an impact on your social interactions and participation in certain social activities, that would be really, it would actually put a spanner in the works if, let's say, you've got a major swallowing problem and you can't then participate in certain activities that you like to, that are related to eating and drinking. But also having a tracheostomy in place, it can actually affect or worsen the dysphagia. Having this redirected airflow can also affect, the pleasures of eating, where smell, taste is affected. And so then the importance of assessing and managing the aspiration risk is really important, because that will then have an impact on the person's quality of life.